Hello, everyone. Give people a minute to sign on. Fantastic. We have, I'm sure other people will be joining us as it's just become 12 o'clock, but we want to make sure that we give ourselves enough time. So welcome everyone to today's MCPAP for Moms webinar on validated screening instruments for the perinatal period. My name is Beth McGinn. I'm the program manager of the program. I'm just going to do some housekeeping. Our webinars are done quarterly, and our next webinar is scheduled to take place on Thursday, July 23rd, where we'll discuss and review important resources that we offer to enrolled obstetric practices. And these include the Maternal Mental Health Helpline, PSI International, and the Massachusetts Behavioral Helpline. Today's session will be recorded, and a copy of the PowerPoint slides as well as a recording will be on our website. Our presenter will stop at various different points to take questions. If you have any comments or questions, feel free to utilize the chat option, and we'll read out your questions and unmute your line if you have a question. We also now offer CMEs for our webinars. So after the webinar, you'll receive a brief survey. We appreciate your feedback. It helps us improve for future presentations. And if you're planning to claim CMEs, it would be required that you take the survey. We appreciate your feedback and improve our future presentations. So let me introduce today's distinguished presenter, who is our medical director for MCPAP for Moms, Dr. Arush Haider. She is also the medical director of the Women's Mental Health Clinical Services and assistant professor of psychiatry and obstetrics and gynecology at UMass Chan Medical School. She is a consulting psychiatrist for Lifeline for Families and enjoys giving state and national talks on perinatal psychiatry access programs that impact and important women's mental health topics. She also serves as the medical student clerkship director for the Women's Mental Health elective in the Department of Psychiatry and has received numerous awards in trainee education, and her particular clinical expertise is caregiving support and sleep and perinatal OCD and psychosis. So with that, welcome, and I hand things over to Dr. Haider.
Thank you, Beth. Everyone can hear me, right? Okay, and as Beth is getting that set up, I'll just share, I was doing drop-off for my kids this morning, and my 3.5-year-old was taking her time, and I was like, Aliana, we have to go, let's hurry it up, and I was like, I have to, get ready for this webinar, and I have 50 slides to get through, and she's like, oh, mommy, can I go down all 50 slides with you? And I thought that was so cute and fun, and her slides are definitely more fun than mine, but I'm going to make this topic on validated screening instruments in the perinatal period as fun as I possibly can. So we do have 50 slides to get through, so let's jump right in, and thank you for being here today. Next slide, please, Beth. Thank you. So the objectives for today are to go over in detail perinatal mental health validated screening instruments, PHQ-9, EPDS, MDQ, the City 3, the Rapid Mood Screener, GAT-7, And the PTSD screeners and the substance use screeners that we'll talk about today are the 5Ps, the TAPS, NIDA, and TWEAK. We will then talk about how to score the validated screening instruments, how MCPAP for moms can help during the screening process, and programmatic updates, and then toolkits and resources. And just as we move forward with these slides to orient us, the AIM bundle, the Alliance for Innovation in Maternity Care, created their perinatal mental health bundles, and they talk about perinatal mental health conditions. And when we talk about that, we're referring specifically to mood disorders, depression, bipolar disorder, anxiety, and anxiety-related disorders like PTSD, OCD, and then postpartum psychosis. So just keeping that in mind, and we always screen minimally before medication and initiation. So we want to screen for depression, anxiety, bipolar disorder. And when we talk about the 5 Rs in the AIM bundle for this webinar, I'm going to focus on the recognition and prevention aspect for each patient. So the first step in that recognition and prevention for screening is really to obtain an individual and family history. And I'll go into that in detail, and then we'll take a deep dive into the screeners. Next slide, please. So perinatal mood and anxiety disorders are recognized as a major public health problem. So many reputable organizations and institutions like the CDC, the USPSTF, CMS, the American Psychiatric Association, American College of Obstetrics and Gynecologists, AAP, all say that one of the biggest barriers to addressing perinatal depression is that it is underrecognized and underdiagnosed. And routine screening can really help address this barrier. Next slide, please. So screening is the first step in the perinatal mental health care pathway. So this webinar will focus on the first two, the green and yellow, the detection and assessment part of this mental health care pathway. When you go through all these steps, the improved outcome for families is always the intended goal. And keep in mind, MCPAP for moms can really help at any point. But just going forward, we're going to focus on the detection and assessment and how to actually do that and what that looks like and how screening fits into that. So screening, recognition and prevention. So we always want to obtain individual and family mental health history. And the next slide goes into that. But I also want to say, that ACOG, their recommendations for screening in the perinatal period are to screen for perinatal depression and anxiety at the initial prenatal visit, later in pregnancy, and that can be the second, third trimester and can be overlapped with the glucola visit with the OB, and again at the postpartum visits. This should always include at pediatric well-child visits as well, and I'm going to get into how that plays a role. And then ACOG also recommends in their clinical practice guidelines to screen for bipolar disorder before initiating pharmacotherapy for anxiety or depression, if not previously done, because of that potential risk for inadvertently putting someone into mania or mood destabilization if you were to give them an SSRI and they in fact had bipolar disorder. So individual and family mental history, how do we actually take that? So individual history, we want to ask about the individual's current diagnoses and treatment, past psychiatric diagnoses and treatment, previous psychiatric hospitalizations, and previous suicide attempts, family history, and if there is a positive history, we always want to, and if the patient is pregnant or not, we want to take that frame of reference in mind and change the conversation based on that. So say the patient is pregnant and they're still on their medications and they're stable. We want to still have the risk versus risk analysis discussion with them so the patient knows how the psychotropic medications they're taking impacts them and the unborn fetus, and also continue effective medications if the patient is agreeable. Now, say the patient, 50% of pregnancies are in fact unplanned. So say the patient just found out she was pregnant and stopped the medications. Or say, she stopped them in the preconception phase before becoming pregnant for whatever reason. You still definitely want to have that risk versus risk analysis discussion with the patient and or call MCPAP for Moms for consultation, and we can talk you through that and work through that with you and what that would look like. So we always want to ask if the patient is currently symptomatic as well. Are they worried about that? And of course, if positive, what do we do? Depending on how that goes. Next slide, please. So screening for perinatal substance use disorders is also recommended. And I'll say AIM, they recommend screening at least once during pregnancy and at delivery with a self-report screening tool, and also to screen for structural or social drivers of health. Screening should always be coupled with adequate systems to ensure accurate diagnosis, effective treatment, and appropriate follow-up. The evidence shows that, in fact, if you were to do a screener if it was positive, if there is no structure or system in place to address that positive screen, that can do more harm than good. So screening is great, but we have to know what to do with a positive screen and what the clinical assessment then looks like and the next steps. And MCPAP for Moms can always help you with that, but just emphasizing that structure really needs to be set in place. Now, next slide, the American Academy of Pediatrics, yeah, the AAP recommends parental depression screening during pediatric visits. So the SWIC now includes the EPDS, which I think is a really important point to note. Previously, it did not, and now it does. So when doing the SWIC, which includes the EPDS, the recommendations are to do it within the first month of the baby's birth, at the 2-month visit, the 4-month well-child visit, and then the 6-month well-child visit. You can also alternatively also do the PHQ-9, because the SWIC integrates the EPDS, not the PHQ-9. And I'm going to get into why that may be important in a couple of slides. So that is available on mcpap.org. And I really like this slide, the scope of perinatal screening, because it allows a really nice visual time frame of that 2-year perinatal period, where so if we divide this to the left side and the right side, the left side is really the preconception, pregnancy, at birth phase, and that's when obstetric visits are really the predominant checkup. The right side, after the baby is born, we shift to more overlap with the pediatric providers. And so this really summarizes how often you're screening, when that looks like. So this integrates ACOGs and AAP recs, which I really like. So if we put that framework for screening and look at all our recs from ACOG, AAP, the bundle, we screen again first prenatally, then each trimester, birth, and then shifting to the right side of the diagram, the well-child visits in the pediatric setting. And so postpartum, we see that less interface with patients and their obstetrical providers that I had mentioned earlier, but more screenings recommended during the well-child visit. So I think it's really important to include what some of our pediatric clinicians may be seeing as well on this webinar. And then the next slide goes into why screening is so important. And I also really like this slide because it really explains why we screen when we do and why it's so important to do so. And I'll add MCPAP for Moms was built off of the very successful MCPAP program, which was built 20 years ago by John Strauss, a pediatrician. And then 11 years ago, MCPAP for Moms was created and applied that model to the obstetric space. And we were built because we wanted to push and advocate for screening. And the why screening is so important and so core to our mission, at certain intervals, it really comes down to the question, in my opinion, of when do these mental health conditions have their actual onset. So if you recall, roughly 1/3 of perinatal depression cases involve symptoms that were already present before pregnancy. So looking at the first blue bubble, the first line, what this means is about 1/3 of these women may come into pregnancy with a condition they already had and did not know about. And then 1/3, moving on to the second line, may develop it over the course of the pregnancy. So every time that we do a screener, we are asking about mental health and decreasing stigma and opening that mental health conversation. And postpartum is really to pick up the last 1/3 of onset of symptoms in the postpartum period. So 2/3 occurs before the baby is born, 1/3 is after the baby is born. And again, AAPs recs that last line throughout the first year of postpartum, keeping in mind we do them at well child visits, also because the peak onset of perinatal mental health disorders is 3 to 6 months postpartum, and the peak incidence of suicide is 6 to 9 months postpartum. So again, summarizing it all, and then we're going to take a deep dive into the screeners. It's more than just a piece of paper and, a number and a statistic. It's really integrating into your workflow and making the time for practices and clinicians and practitioners to ask your patients and all perinatal individuals, what is your mood like? It allows you the opportunity to ask about their mental health and really protect that time and space in the visit. So that's why screening is so important and why it's so important to MCPAP for moms in our mission. Next slide. So validated.
Before, sorry, there's a question
Oh
in the
yeah.
chat. Do you have any thoughts on the Columbia Suicide Severity Rating Scale and the Beck scale?
That's a really good question. Thank you, Beth. I actually can't see questions coming in. So that's a great question, and I am going to answer that at the end because I do reference one of those questionnaires, and I'm definitely going to come back at the end. So please feel free, please put all your questions in the chat, and I'll respond to them all at the end. Okay, validated screening instruments, depression and anxiety. So for this webinar, we're going to look into depression screeners are EPDS and PHQ-9. Anxiety is going to be the GAD-7. And then numbers 3, 4, and 5 on the EPDS look into that anxiety component on the EPDS. The PHQ-9 does not have an anxiety component. So ACOG recommends that when someone scores positive on the self-harm or suicide question, then the clinician should immediately assess for likelihood, acuity, and severity of risk of suicide attempt, and then pursue a risk-tailored management plan. So I think it's important to remember for the depression screener in particular, in EPDS, it's the number 10, and the PHQ-9, it's the number 9. It's the 9th question. Those are the two questions that directly speak to self-harm. So this kind of goes into the question that was just asked in the chat, but remember to always look at those questions. And then you can also follow up with other screeners like the CSSR that you had mentioned and the Beck. But anything other than never on 10 on the EPDS or 0 on the PHQ-9 warrants further clinical assessment. So while most people while most people who score low on that 9 or 10 are not at active risk of self-harm, it really still needs to be clinically addressed. And I'll also add the screeners that we're going to go into, they're not the only screening instruments out there. I have cherry-picked these for this webinar because they are the ones that have the strongest evidence. They're easy to administer, mostly filled out by the patient, validated in so many languages. They're very easy to score, quick. They're also the ones that are highlighted on ACOG, the CPGs, and the Patient Safety Bundle, and AAP and the SWIC in the EPDS. So the next slide goes into the score on screeners always correlates with illness severity. So remember, screening instruments are not diagnostic tools and have correlation with disease severity. And symptom severity then directs treatment intensity. So feel free to screenshot this slide. I like it because it's a nice summary of the EPDS, PHQ-9, the GAD-7, and the trauma questionnaire scores, and it categorizes them into mild, moderate, severe. So remember, generally for moderate to severe scores, we want to discuss and talk about pharmacotherapy. And the evidence shows that really for mild, moderate, and severe, we always want to recommend psychotherapy for the patient. So now we're going to go into assessment. So to assess, we want to ask about symptoms and illness severity. So recent stressors. What are the duration of your recent symptoms? How often do the symptoms occur? Any feelings of hopelessness or helplessness in particular? Current medications and or therapy, family psychiatric history and substance use disorder history, previous symptoms, previous suicide attempts, past psychiatric treatment, medication or therapy, previous psychiatric hospitalizations, current suicidal ideation, plan, and intent. I'll also add about that last bullet that it can be challenging to assess for risk of suicide, and it can be uncomfortable for a lot of providers to ask about that. Understandably, it's a very hard topic. And so the conversation and asking about self-harm, I recommend the Lifeline for Moms toolkit and the MCPAP for Moms obstetric provider toolkit that's actually going to be updated this spring. But the Lifeline for Moms toolkit was just updated, and it can really help breach this topic. And it goes through lists of questions such as we're here to support you and help you. And we do ask about these thoughts because they're in fact so common for so many different people and they can commonly occur. And statements like that in the tool can really help remove the stigma, and it can make it easier to having that conversation. And I'll also add, when building the toolkits, the authors of the toolkit, they went through all those questions with persons of lived experience, and they shared the suggested experience of those persons with lived experience. So I feel like that's a really good resource in particular for everyone to look into. So just wanted to put that in there. And then this goes into the ASQ, the Ask Suicide Screening question. So the ask is the ASQ is it's a questionnaire as a suicide risk screening tool that's validated for both youth and adults and women and men. So while not particularly validated in the perinatal population, it is still validated for both for youth, adults, women, and men. It's approved for all ages in all clinical settings, inpatient, outpatient, emergency settings, and it identified those at risk for suicide. So those are the 4 questions on the side that I pulled for the NIMH. It is so quick and easy to administer. I mean, it can be done in under a minute. And I think that's even generous. It can really be done in like 30 seconds. It's so fast and easy. And if anything is positive, if there's a concern for imminency or a further urgent clinical assessment is needed, you want to contact the Massachusetts Behavioral Health Helpline, 833-773-2445, and they can help you with that clinical assessment and will connect you with an embedded clinician right away. And then, crisis can be discussed and further options. So that's what you should do if you have concerns about the scores on that screening tool. And if there are any non-imminent questions about suicide or general questions or concerns, you can always call MCPAP for Moms and we can talk about that with you. So now shifting back to the depression and anxiety screeners. So MCPAP for Moms has created an EPDS score-based follow-up guide. And we created this to help practices and you all navigate the EPDS because it is so commonly used. And we stratified this based on EPDS scoring. And we encourage you to call at any point. We're here to help. We can help you with any safety concern questions. If it's non-imminent, a risk assessment, what that looks like, what is a risk assessment, a Section 12, how to navigate it, when to send someone to the hospital. So again, that's stratified based on 0 to 18 and 19 to 30. And that is available in our updated MCPAP for Moms obstetric provider toolkit that will be updated and released this spring. So just wanted to give you a peek preview to that. And now we're going to go into the EPDS. So the EPDS is a validated depression screening tool for use in pregnancy and the postpartum period. So greater than or equal to 10 is a positive screen. The EPDS is 10 questions and number 10 looks at self-harm. The maximum score is 30 and it does have that anxiety subskill component, numbers 3, 4, and 5. Mostly 4 and 5, but I'll say also 3, 4, and 5. I blame myself unnecessarily when things went wrong. I've been anxious or worried for no good reason, and I have felt scared or panicky for no good reason. It is validated in perinatal populations. It's available in well over 40 languages. It looks at less physical symptoms and more cognitive symptoms, and it looks at symptoms over the past 7 days. So the EPDS will indirectly measure more cognitive symptoms such as guilt, decreased self-esteem, feeling sad, versus trouble sleeping, change in appetite, other physical symptoms that may also overlap with depression. And the PHQ-9 will look at more of the latter, and I'm going to compare and contrast that in a bit. And so the next slide, this is the full-blown EPGS, and this is also going to be in our obstetric provider toolkit. And then when we look into the scoring, so questions 1, 2, and 4, these 3 are scored as 0, 1, 2, or 3 in that order, with the top box scored as 0 and the bottom box scored as 3. The remaining 7 out of 10 questions, 3, 5, 6, 7, 8, 9, and 10 are reverse scored. So the top box will be scored as a 3 and the bottom box will be scored as a 0. The maximum score possible is a 30. Remember, a positive score on the EPGS is 10 or greater, and we always want to look at 10 suicidal thoughts, which is the equivalent of 9 on the PHQ-9. And again, it's important to remember that screening instruments are not diagnostic tools. You will not diagnose depression by using the EPGS. And however, the EPGS, it correlates with disease severity. And by using that tool, you can identify individuals who have symptoms consistent with mild, moderate, or severe depression. So when, again, a summary of the scoring, sum the columns and then sum the column totals based on what I had just discussed on the last slide and following those rules exactly. A positive screen is 10 or above and or a non-zero response on the last question, number 10. The maximum score is 30. Always look at number 10 and follow with further clinical assessment or call MCPAP for moms if you have any questions. I'll also add, it is so important that the EPDS is scored before your client leaves their appointment, so that if there is a positive screen, you could catch it then and there and promptly address it with the individual. So just wanted to give you all that reminder. Now we go into the PHQ-9. So the PHQ-9 is a validated depression screening tool for use in pregnancy and the postpartum period. PHQ-9 greater than equal to 10 is a positive screen. It has 9 questions. So number 9 looks at self-harm. The maximum score is 27. It's validated in perinatal populations available in over 100 languages. It looks at more physical symptoms and less of the cognitive, in contrast to the EPGS. And it looks at symptoms over the last 14 days, whereas the EPGS looked at symptoms over the last 7 weeks. So those are the similarities and differences. So in general, I would say the EPGS is better at asking, are you emotionally struggling, versus the PHQ-9, which is going to ask more of what is your thinking like and how is that impacting your mood. So the more physical questions are going to be targeted by the PHQ-9, like sleep, appetite, actual concentration. There's actually a question about concentration in there, moving, speaking slowly, etc. So how do we score the PHQ-9? We want to sum the columns and then sum the column totals. A positive screen of greater than 10 and or a non-zero response on the last question. Sorry, that should be number 9. On the last question, number 9, not 10. The maximum score is 27. Always look at number 9. That's a question that looks at suicidality, and follow with further clinical assessment or call MCPAP for moms if you have any questions. Now, EPDS or PHQ-9, I'm often asked, Dr. Hager, if I was supposed to pick one of these, which one should I do? I only have time for one. I would be like, great that you're even asking these questions. Historically, MCPAP for Moms has recommended the EPDS for various reasons. It's, validated for only the perinatal population. It literally is the pregnancy, postpartum depression, anxiety screener. But I'll say MCPAP for moms now actually recommends the PHQ-9 over the EPDS for a couple of reasons we've seen since the program was created 11 years ago, and for a couple of clinical reasons I see pretty often. So the PHQ-9 has more longitudinal coverage over the perinatal lifespan. It can be used during gynecological visits. Whether or not the patient is pregnant at any age that there is a gyne visit, you can administer the PHQ-9 and follow that on and compare it to the patient's baseline, compare it to years later, whereas the EPDS is really only used in pregnancy and postpartum, so it's not directly applicable across the whole perinatal lifespan. And this is something we've really saw over the development of the program over the past decade. The PHQ-9 is more commonly used in primary care settings. So, a lot of our primary care colleagues call us with the PHQ-9. So that's one thing to keep in note. I'll also say PHQ-9 can be used in the perimenopause phase and beyond. I am clinically seeing and treating many patients who are pursuing IVF or trying to have kids in their late 30s and early 40s. And oftentimes this does overlap with the perimenopausal phase and beyond. So for example, I had a patient who got pregnant and had her first baby in her early to mid 40s, and pretty soon after she was exhibiting signs and symptoms of menopause. And I liked doing the PHQ-9 because she already had that baseline prior to pregnancy in the preconception phase from her primary care doc. And I did it during pregnancy and then soon after she was menopausal. And you wouldn't be able to use the EPDS in that menopausal phase, whereas the PHQ-9 you can. And so it's becoming more common for women to have kids later in life. So that's why I think the PHQ-9 has that more longitudinal coverage. And it is DSM based, correct? So I hope that clinical insight is helpful in understanding that. And onto the GAD-7. So the GAD-7 is a validated anxiety screening tool for use in pregnancy and the postpartum period. The GAD-7, a score of greater than or equal to 5, is a positive screen. It looks at symptoms over the past 2 weeks. It's 7 questions total, GAD-7. The maximum score is 21, and it's validated in perinatal population. So how do we score the GAD-7? So we want to sum the ratings for the 7 items. The maximum score is 21, and we will follow with further clinical assessment or call MCPAP for moms. It's pretty straightforward. And again, the EPGS has 3, 4, and 5 that look at anxiety. So it kind of, obviates the need for GAD-7. But if you're going to do the PHQ-9, if possible, it would be great to follow up with the GAD-7 if you have the time to do so, because it will delve into the anxiety component that PHQ-9 doesn't necessarily go into. So now we're going into the screeners for bipolar disorder. And bipolar disorder is particularly common during the perinatal time period as compared to other time periods. And this is the Catherine Weisner 2013 JAMA Psychiatry study is something that you've certainly seen me cite before in previous webinars because it's so important, because this was the largest scale depression screening of postpartum women and the first time a full psychiatric assessment had been done in a study of postpartum women who screened positive for depression. And the study, which included a depression screening of over 10,000 women who had recently delivered, revealed that a large percentage of women who suffered revealed a large number of women who suffered from recurrent episodes of major depression. And the most common primary diagnoses were unipolar depressive disorders at 69% in the blue you see, and almost 2/3 had comorbid anxiety disorders. And of the women who screened positive for major depression, 23% in the green had bipolar disorder, the majority of whom had never been diagnosed by their physician before. And so I think the takeaway from this slide in this study is it unipolar depression or is it bipolar depression after you've done a screen for depression? So 23% of the time, so emphasizing that proportion in the green, 23% of the time, a positive EPGS screen is in fact bipolar depression. That is not a small fraction at all. I can't emphasize that enough. So that's why it is so important to do the next part of the screening. So that's 1 out of every 4 patients who score positive on the EPDS actually has a bipolar depression. And what that means is it means different treatment. That's giving a mood stabilizer, an atypical antipsychotic, a risperidone instead of a Zoloft, instead of an SSRI. a lamotrigine instead of a Prozac, because we know that prescribing unopposed antidepressants can inadvertently precipitate mania and increase the risk of other negative outcomes. That's something that ACOG and the CPGs say. So just wanted to emphasize that side. So any questions about MDQ rapid mood screener, please call us. So we're going to go into the two now. The mood disorder questionnaire is a self-administered screen for bipolar disorder, and it screens for the lifetime presence of bipolar disorder. So PHQ-9, GAD-7, EPDS, those tend to be really the last 7 to 14 days. The RMS and MDQ are not that recent. So yes or no questions. It's pretty straightforward. It's validated during pregnancy, sensitivity 89% and specificity 84%. And really, anything positive warrants further clinical assessment with a perinatal clinician or call MCPAP for moms. And I can't emphasize that enough because of the last slide. 23% of the time, a positive EPDS can be MDQ. And so if you do have a positive MDQ or RMS, you want to look into that further. So, just to compare the screeners for bipolar depression, those for depression anxiety, remember, remember that fact. And then I think the next slide, we will go into the actual scoring and the MDQ screens for lifetime history of mood elevation. We total number of Y responses from question 1, and a positive screen is yes to greater than or at least 7 of the 13 symptom questions, yes to simultaneous symptoms, and yes to a moderate or severe problem. So the scoring on the MDQ is pretty straightforward and quick. And then the City-3 question bipolar syndrome is another screening option on the next slide. Thanks. And that needs to be asked by the provider. And so the way that this works is so this is from the Lifeline for Moms perinatal mental health toolkit. So remember, it's not self-administered. It needs to be asked by the provider. So first you ask question 1. Some people have periods lasting several days or longer when they feel much more excited and full of energy than usual. Their minds go too fast. They talk a lot. They're very restless or unable to sit still. And they sometimes do things that are unusual for them, such as driving too fast or spending too much money. Have you ever had a period like this lasting several days or longer? Then you go on to number 2. Have you ever had a period lasting several days or longer when most of the time you were so irritable or grouchy that you started arguments, shouted at people, or hit people? If yes, if yes to questions 1 and or 2, then you continue the screen for bipolar disorder and ask number 3. And number 3 is long. I'm not going to read it out, but if yes to number 3, then the screen suggests that the patient has bipolar disorder. And at that point, you do not prescribe an antidepressant. You want to consider a mood stabilizer or an atypical antipsychotic or call MCPAP for moms, and we can talk about that with you. And if no to question 3, then you want to pursue the treatment algorithm for unipolar major depressive disorder, and this is likely not bipolar disorder. So yes, so that's what I'll say for the City-3, and then we're going to go into the RMS. The rapid mood screener is the 3rd type of bipolar screener that I'm going to bring up in this webinar, and it's another screening option. And I actually like the RMS the most of the 3. It is relatively new. Some of you may not have even heard about it yet, but I like it because it's so quick and easy, and it has much better sensitivity and specificity than the MDQ. So what the RMS does is it differentiates bipolar 1 disorder from unipolar major depressive disorder. It is validated during pregnancy. Sensitivity of 0.88 and specificity of 0.80. Compared to the mood disorder questionnaire, it is quicker and easier to implement. And those are the questions on the right of the RMS. When we score the RMS, a positive screen is when the patient scores yes responses to 4 or more of the 6 items that is considered a positive screen, indicating that there's a high likelihood of bipolar disorder 1 because the sensitivity and specificity is high. So just remember, each yes counts as 1 and each no counts as 0. So it's pretty straightforward. And a positive screen should be followed by clinical assessment or call MCPAP for moms. So again, just to summarize the RMS, it's a brief self-report screening instrument for bipolar disorder 1 that takes less than 2 minutes to complete, and a positive screen should be followed by a comprehensive evaluation. And we use the EPDS and then the RMS or the MDQ to prevent inappropriate treatment. So just tying this all together, medication treatment for bipolar depression is different from unipolar depression. So by accurately diagnosing bipolar disorder, we're doing two things. We're maximizing the use of evidence-based treatment for bipolar disorder, and then we're also reducing the chance of unintentionally inducing mood and elevation or a switch into mania or hypomania. And the RMS is in the updated MCPAP for Moms obstetric provider toolkit that will be put on the website this spring. So now we are going to go into the PTSD questionnaires. So the first one is the PC-PTSD-5, the primary care PTSD screen for DSM-5. It is quick and easy to administer. It focuses on symptoms in the last 1 month. It is validated in perinatal populations. The maximum score is 5, and a positive screen is any score greater than or equal to 3. It has very high sensitivity and high specificity. And of course, after doing the PC-PTSD-5, you can always consider administering the PCLC if you do have time. And so just wanted yeah, I'll mention that in the next slide. So the scoring for the PC-PTSD-5, how do we score it? If the first column is no, then the column is 0. Pretty straightforward. If the first item response is yes, sum the number of yes for the last 5 questions. Just keeping in mind, this starts after the horizontal bolded black line that says, in the past month, have you? Because the question above, have you ever experienced this kind of event? Please circle the response that indicates your answer, yes or no. That does not actually count in the scoring. Just want to point that out. There really just notes that there has been a traumatic event in the past. Or any of the above in the bullets, a serious accident or fire, physical or sexual assault or abuse, earthquake or flood, a war, seeing someone be killed or seriously injured, having a loved one die through homicide or suicide, or anything the patient perceives as traumatic, even if it's not on that list. I want to emphasize that. So again, you tally all those up. A positive screen is a score greater than or equal to 3, and then consider following with a PCLC-C, which is on the next slide. So the PCLC-C, thank you, is the post-traumatic stress disorder checklist for civilians. It is validated in perinatal populations. It's based on the DSM-4, I'll say, but it's still widely used, so that's why I put it in there, and it's validated in pregnancy and postpartum. It is widely used in primary care settings. It's on a 1 to 5 rating scale, ranked as not at all, a little bit, moderately, quite a bit, extremely. A positive screen is greater than or equal to 30. A maximum score is 85. It is definitely on the lengthier side, so if you have time to do this, that's great, but certainly not an expectation for a busy obstetric practice or any of you who don't have the time. The PCLC-5 is a great introductory alternative for assessing for trauma. Let's see. So sum the ratings for the PCLC items: positive screen greater than or equal to 30, maximum score is 85, and always father refer their clinical assessment for PTSD or call MCPAP for moms. So now we're going to get into validated screening instruments for substance use disorders. So ACOG and SAMHSA recommend universal screening for all pregnant women. So I'll also add that the Massachusetts Department of Public Health, DPH, recently stated that there is no proposal to require a specific screening tool in substance use disorders. It's just that screening should occur at least once during the perinatal period using a validated screening instrument. And the AIM bundles have mentioned that too, and that was in my earlier slide in the webinar. So we always want to encourage universal screening for all pregnant women, and a positive screen does not equal diagnosis. And as always, screening instruments do not mean that there's they don't diagnose a substance use disorder. They screen for what will likely be problematic use. So I want to emphasize that and keep that in mind going through these screening instruments. A positive screen should, again, always be followed by is clinical assessment or call MCPAP for months or treatment referrals, or, are you interested in getting someone who can help with motivational interviewing for your patient? Harm reduction, I think, should always be part of the discussion. We can talk about that with you. And I would say substance use disorder is also a really big opportunity to talk about and integrate trauma-informed care, especially if there's that overlap with that. So the four screening instruments I've picked for this webinar are the 5Ps, TAPS, NIDA, and TWEAK. There are many more, but I'm focused on these in this webinar. So the 5Ps, the substance use disorder screen, I like this because it's introductory, it's quick, it's so easy to ask, it's validated in the perinatal populations. And we go through it uses the 5Ps mnemonic: parents, peers, partner, pregnancy, and past. So it's these 5 questions. Did any of your parents have problems with alcohol or drug use? Did any of your friends have the same problem? Does your partner have this problem before you were pregnant? Do you have problems with alcohol or drug use in the past month? Did you drink beer, wine, liquor, or other drugs? So it looks at substances used in the current pregnancy and in the past, and it probes into family history. A positive screen is 1 or more. Super straightforward, easy to use, and it's a Massachusetts DPH recommendation, the 5Ps. And that's what I'll say about that. So, and then we'll go into the TAPS, tobacco, alcohol, prescription, medication, and other substance use tool. So the TAPS is definitely a little bit more comprehensive and longer. It's validated in perinatal populations. It looks at more broad substances. It's patient or clinician administered. And the way it's scored, it gives you a TAPS score and then a risk category. So it has those 2 components, and it looks at the last 3 and 12 months of use. If you're looking for something more comprehensive with more resources, TAPS is a good alternative because it includes suggested action and additional resources, and it's recommended by ACOG. And so, for example, on the right, this is a screenshot I pulled from the website. I put in a sample question, a sample patient, with just, sample responses. And as you can see, the way that they stratify and risk it: sedative use, risk level, undetermined risk, and it goes into what that actually means and suggested course of action and additional resources. So it has those 2 components. And, the first component is that 4-item screen for tobacco, alcohol, illicit drug use, and non-medical use of subscription use. And then if the individual screams positive in the TAPS 1, the school will automatically go into that second component, which is called TAPS 2. And that looks into a brief substance use specific assessment question to arrive at the risk level for that substance, which is what you see here on the right. Next slide. So the National Institute on Drug Abuse, NIDA, quick screen, the modified assist. So this has good specificity. Many of you probably know of the NIDA. So it's a 2-step workflow. It has that quick pre-screen and then a follow-up severity assessment. It goes through a DSM-oriented severity follow-up. It is provider administered. It is long. It's about 70 questions. It can take from, 5 to 20 minutes, depending on what the responses are, and it's validated in perinatal populations. So this is the screenshot on the right is the quick screen question, the initial in the past year. How often have you used the following? Alcohol, tobacco products, prescription drugs for non-medical reasons, illegal drugs. And then depending on that, you then go into something just more comprehensive. So that's what I'll say about that. And it is validated in perinatal populations. Next slide. And then the TWEAK, so TWEAK I put in here because it's validated in perinatal populations, and a lot of OBs like using it because it's so quick and easy, and it looks at the mnemonic as tolerance, worried, eye openers, amnesia, K, or cut down. And the questions are pretty straightforward. How do I screen for alcohol use during pregnancy is really the question that comes to mind when I'm thinking about using Tweak. So it really, the goal of the tweak is to identify at-risk drinkers and pregnant women only. So it's specific to this population. It is not a general substance use disorder screener. It really assigns points on risky drinking behaviors only. And the maximum is 7, 2 points, 2 points, 1, 1, 4, 5, 6, 7. So pretty straightforward and quick and easy to screen. So again, what should I do with a positive screen for any of these questionnaires that I just went through? So we want to start with MCPAP for Moms EPDS score-based follow-up guide if you're doing the EPDS. For any of the other screeners, follow with a clinical assessment or go to page 18 of the Lifeline for Moms toolkit assessing perinatal mental health, or go to page 19 of Lifeline for Moms toolkit, which is starting treatment for perinatal mental health conditions if you're confident with the diagnosis and want to go into actual treatment. And you can also, if you want a very high level, brief overview of what to do next, the MCPAP for Moms Obstetric Provider Toolkit, again, is updated and will be available on our website this spring for next steps. And can't emphasize enough, call MCPAP for Moms and at any time to ask questions on validated screening instruments during a phone consultation with our psychiatric consultants. Even if you have questions on how to get started, even if you've never implemented or offered a screener before, it doesn't matter. Call us, we'll help you and tell you how to get started. That's, what we're here for. That's how MCPAP for Moms came to exist based on these screening instruments. So these are the toolkits and e-modules that are available for all clinicians, obstetric and non-obstetric, through ACOG. So the left is the perinatal mental health e-modules. Thanks, Beth. And the right is the Lifeline for Moms perinatal mental health toolkit that many of the screenshots on this webinar came from that toolkit just because it's so comprehensive and easy to use. And then the asynchronous modules, are on the NIMH the ACOG website. And this was a grant-funded asynchronous module that really is like a crash course on perinatal mental health. So if you're looking for something more interactive, I highly recommend that. It can be a great tool. And all of these will go into the screening instruments as well. So the SUG treatment provider toolkit also was recently updated and will be available this spring on our website. I want to give a shout out to the MCPAP for Moms SUG substance use disorder program, and our SUG program is dedicated to SUG concerns in the perinatal setting. So if you want to talk to a member to someone in the SUG program, the program coordinator or associate medical for SUG, please call the main MCPAP for Moms line, inquire about the program, and our SUG manager Gina Gallagher will get back to you. The SUG toolkit, it took 2 years to create. It was finished in 2021 and we just updated it this spring, and it will be on our website soon. And it looks at SUG in the first half, followed by 3 fact sheets addressing non-stigmatizing language, trauma-informed care, reproductive life planning in the SUG setting, and the second half focuses on the psychiatric concerns. So that's the high-level summary of the SUG toolkit. And then other MCPAP for Moms updates, the Dual Link toolkit will be available this spring on our website. And this is new, and doulas have been able to call MCPAP for Moms since February of this year. So if you're a doula on this call, if you know a doula, please encourage them to call us about any questions they may have, especially about resources that they want to offer to their clients. And MCPAP for Moms collaborated on a Dual Link toolkit, and we're excited to have that on our website for all doulas or anyone interested. And other SUG program updates, MCPAP for Moms is supporting DPH, BSAS, and other state programs and agencies with the launch of the Family Care Plan. And that's linked to new policies on reporting. So more to come on that in the fall, and our October SUG webinar will be on that topic. And the SUG program is doing ongoing outreach to programs in areas of Massachusetts with high levels of perinatal substance use and low access to treatment. And so if you any questions about that, please always call us and Gina will get back to you. And there's a new DPH mandate. All perinatal individuals should be screened at least once during pregnancy, ideally at the first prenatal visit. And always as a reminder, toxicology testing is not as a substitute for screening and is not required. So any questions about that, please call our SCG program. And we look forward to seeing you at our future MCPAP for Moms 2026 webinars. The next will be in July on general perinatal mental health, and family care planning will be discussed in October's webinar. And these are a list of resources vetted for you all. And I guess, Beth, I want to go back to the question that was asked because we have 5 minutes, and then I'll open it up to more so we can stop the screen share. Someone had asked about the Columbia Suicide Severity Rating Scale and the Beck Scale for suicidal ideation. So what I'll say about the CSSRS is, so that's considered the gold. So I went into the ASQ in the webinar. I didn't go into these two. And so if you have any questions about those and why you're doing it, certainly call us. And if it's something, more urgent, call the Behavioral Health Helpline, especially if one of these comes out as positive. But just to compare the two, the CSSRS is considered the gold standard for assessing for suicide risk. And it's endorsed by many organizations, CDC, WHO, the FDA. It is validated in pregnancy. So I think that's important to know. It's very evidence-based. We have so much data on the CSSRS, and it assesses for suicidal ideation and behavior. And what it does, it determines the risk levels to guide immediate intervention, not on numerical scores, but on like none, low, moderate, severe. So that's how it scores. It doesn't really generate a numerical number. I will say it's widely used in so many clinical settings. It is integrated into the EPIC workflow at UMass in our outpatient psychiatry department, but also in schools, and many other academic hospitals and our other hubs in Massachusetts have that integrated. So that's kind of considered the gold standard. And I know it's available in like almost 200 languages, so it's widely used. In contrast, uh, the Beck scale for suicidal ideation is also well known and widely used. What's different about it is it's like a 19-item self-report questionnaire, whereas the CSRS is clinician administered. And the Beck measures the intensity of individuals who suicidal ideation, and it can be used with the CCSRS, but it applies to patients who are already at risk of suicide. So that's why I had mentioned, you can complement the Columbia with the Beck, but the Columbia is more widely used and is considered the gold standard. The CSSRS is also looks at signs and symptoms that are more longitudinal, and the Beck is much more recent. I think it's about suicide ideations that occurred in the past 7 days. So that's my summary for that. And let me just see.
Yeah, we had a few other questions.
Okay, great. A question for later. Given how many of the validated or widely accepted perinatal substance use screening tools have real psychometric limitations like forced specificity, forced specificity, performance that varies by race and ethnicity, what do you actually think best practice looks like now? It's a great question, Alexandra. Yeah, I think for the substance use screening tools, I think more research has to be put in for specific sensitivities and specificities and valid. As you noticed, I gave ballpark figures on those, whereas for the other ones earlier, like the EPDS, we have more concrete numbers. I would say if you're going to start with something, the fact that you're even thinking about a screener for a substance use disorder speaks volumes. So just great, kudos to you on that. Just wanted to emphasize that. And you can start with the 5Ps just because it is so broad, and then you can hone it in depending on what they score positive for with any of the others that I had mentioned. But again, the fact that you're just getting started is huge because substance use disorder in the perinatal space is often siloed. So I think integrating that and thinking about that is big on its own. Can you comment on a fair timeline for screening for catatonic symptoms in postpartum periods up to a year for screening? For example, should we be planning for weekly scales, perhaps for a certain duration? In terms of best practices, I don't know if there is one for catatonia in pregnancy. That I certainly am not familiar with one. I would say weekly for whatever you're doing, for especially clinical assessment. I think weekly absolutely makes sense. I think inpatient and outpatient setting also, plays a big role. If it's something more severe, you would probably want to monitor on a near daily basis. So I think taking that risk stratification into picture, I think plays a big role too. It's a great question. Great presentation. Thank you very much. Are we able to get a copy of the PowerPoint? Absolutely. And the slides and recording will be up. Thank you for this great webinar. There is current legislation and public comment that will require clinicians to report substance exposure, including cannabis, as well to the state and will include identified names to a database. This new legislation will interfere with screening tools because patients will need to know that such responses will end up in a patient identified database. Linda, thank you so much for saying that. That definitely makes sense, and I agree with that. And we can certainly talk about that more if anyone has questions, so please call us. But Linda, that's very helpful. Thank you. Lastly, Kathleen, in administering the tools, often moms want to talk about what causes them to answer the question. Is it better practice to go through questions or stop, address the questions, and continue on with the questions? That's a great question, Kathleen. I would say, especially since the goal is to follow up with any type of screener, especially if positive with the clinical assessment, if they want to talk about it, like or have questions about clarification, which will often come up, especially in the EPDS, believe it or not, because a lot of patients, even clinicians, don't realize that it only looks at symptoms in the last 7 days. If they have questions at any point, absolutely go through it. By administering this tool, you are doing what you're supposed to, which is opening the conversation on mental health with the patient. So if at any point they want to talk to you about that or want to elaborate more, whether it's 5 seconds in, 5 minutes in, pause and talk about that with them. I think that's great. That's a great question. We are at 1:02. Thank you everyone for coming. Appreciate it. And thanks for staying 2 minutes over. Needed a chug of